Okay, hello. Okay, so today, thank you all for coming to the Together in Care webinar on the pediatric and neonatal palliative care. So today, the speaker is Dr. Jennifer Linebarger, and her talk will be on who gets palliative care in the NICU. So just before we start, we wanted to let you all know that the continuing education credit is available for these sessions, either live or recorded, which you can access through the QR code, and MOC Part 2 is offered as well. So just as a preview for the next webinar, the July webinar will be on successful palliative care transitions from NICU to home by Dr. Renee Botts, who is a neonatologist and palliative care physician at Johns Hopkins, and reviewing considerations of taking patients to home, such as methods of transport, logistics, meds to order at discharge. So that will be coming up in July. The registration QR code is directly below that. You could register ahead of time to come to that webinar. And then just the other QR codes on here, the one on the left is a link to the Together in Care website, where there's all the information for this series. And then on the right is the TCAN advocacy website that you can get to. All right, so I'm going to turn it over to Dr. Linebarger for her talk now.
Hi guys, I was really excited when everyone reached out and let me know about the TCAN project this year, and really suggested that we talk today about who gets palliative care in a NICU. And part of why I'm here chatting about this is I am a palliative care physician who runs a busy program at Children's Mercy in Kansas City. I am not a neonatologist by training, and the NICU and perinatal world is where I spend a lot of my time, and am excited to share with you a little bit more about what that looks like and think considerations to have for where you are as well. We put together a few formal learning objectives for you. We will talk a little bit about aspects of program development, and how that impacts what palliative care might look like where I am compared to where you are. I will offer my own ideas around criteria for who may benefit from specialty palliative care within a NICU setting. And through all of this, we'll then have a chance to examine some of the concepts of uncertainty and parallel planning. So one of the things that came to my mind as I was making sure I had my disclosures, in the era of not actually having any financial disclosures, I do like to think about what else and what other biases we may bring to the table. And so, one of the biases is that I've been doing this now, where I am since 2011. And the field has really changed a lot since then and when we got started, even though it doesn't feel like very long ago. And so one of the ways to put that into a visualization was just to sort of do a little PubMed search on perinatal palliative care. And you can see that there were a handful of articles published in 2011 and many, many more in the years since then. And similarly, even with the combination of palliative care and neonatology. And so all of that to say is that the field of palliative care continues to evolve, and yet it is still new enough that the evidence base and the use of clear outcome metrics remain pretty limited overall compared to practices you may experience within neonatology. The other piece of the disclosure is I am somebody who lived on the East Coast for 8 years, and I recognize that there are many people who don't know where Missouri and Kansas are. And so while this is not showing you where they are on a map of the continental US, it's safe to say that they are dead center. And so what a lot of people would consider flyover country. I put the map up just to sort of give a sense. I use this slide or this map in a talk on palliative care transports, and just an example of the patients that we meet may come from more than 400 miles away from where our hospital is. And so that creates its own set of challenges that some other centers encounter as well, but that many others do not. Our center is the only quaternary children's hospital in all of the state of Kansas, even though we're actually in Missouri. Um, and then we have a partner in St. Louis, not a partner, but another children's hospital. But between here and there are also limited options. And so it's from that place that really our teams bring in patients. Our fetal health center opened in 2010. We started embedding palliative care in it pretty quickly after patients started coming in. And so we'll talk a little bit more about what that looks like. Our neonatal ICU has been here for quite a while. However, it wasn't until 2019 that they had the development of a specialized small baby unit for those who are truly at that peri-viability age of gestation. And we have also done work to embed ourselves within that unit. And so we'll talk a little bit about what palliative care looks like in those spaces over the course of the talk today. I also can't help myself in thinking a little bit about um, program development. It's something I love and something that you also don't really get training in. And so some of the ways that I think about this is thinking about who are these patient populations. And so really that's the bulk of the talk today. The other really important things to consider, though, are who are your champions? Who's going to help you be the person in the units that ensures you're really meeting all the patients that you want to? Who helps stand up for the role that palliative care plays when it's new and a little foreign to some of the other colleagues that are in that unit? And I can imagine that those are real challenges at many neonatology programs still. And so we'll talk a little bit about um, what to consider in my own personal experiences as we grew a program, and how thinking about and returning to these ideas of what does the care model look like plays into that as well. So when I think about who are the palliative care patients, I usually think about the surprise question. It's something they teach us in fellowship. It's been long used to identify when palliative care referral can be beneficial in adult medicine. And in February of this year, our colleagues in Barcelona, Spain, actually published how the surprise question works within neonatology. They ask the neonatologists at admission, at 7 days of hospital stay, and at 28 days, and then compared that to the patient outcomes at 12 months. And what they found is that there is a high sensitivity for this question, even within neonatology. And so it really could serve as a tool for us to figure out who might benefit from specialty palliative care. We'll return to this question a few times because I think it's really important. The other two questions I use in thinking about palliative care is, first, does the patient have an uncertain prognosis? And second, do I anticipate there being really complex medical decision making ahead? So this may be counter to I need to feel certain that this child will not survive in order for me to feel comfortable reaching out to palliative care. Or it may be, I don't know, there might be a complex care scenario in which we're talking about trachs, but our hospital would actually take custody of the child to make sure they get one. So there's really not a complex decision to make. There's not really a choice that the parents are facing. And so using these questions has really helped us be thoughtful about when and who makes sense to meet palliative care. I used these questions as we were thinking about what we would be doing in our fetal health center as uh, this group here is a group of neonatologists who may resonate with the fact that the first year of my very first attending job is when the fetal health center opened, and I was the only palliative care doc here, working to make the case for why we should be a part of perinatal palliative care as the fetal health center opened its doors. And thankfully, the palliative care team that I came into as a physician had a group of nurses already working in it, who from early on in the creation of the team had been actively involved for patients with single ventricle physiology. And so the first and the main group of patients referred to palliative care at our institution were those with hypoplastic left heart syndrome. And so that helped make the case for why palliative care would show up in a fetal health center. Because if we were meeting all of these kids with single ventricle physiology after they were born, why not also consider meeting them before they're born? And so it was very much from that place and that stance that we were able to bring ourselves into the fetal health center, and really work together in some remarkable ways, to build a program. And we actually published on the program development here, in, gosh, when did we publish this? Uh, 21, I think. Um, what we looked at were the outcomes after our team had met. Because at the time we were building this, a lot of other centers still had that stance that palliative care only needed to be involved prenatally if the child was not going to survive to a discharge home or more than a week or two of age. And this really was a very different lens to view what palliative care might offer. And so we tracked what went on with our patients. What did we do? And so we were using our own version of the surprise question. Would I be surprised if this child died in the next 12 months? And what we realized is that for a lot of babies with a congenital diaphragmatic hernia, you wouldn't totally be surprised, right? We know that survival statistics are scary for that patient population. And we have a hard time predicting prenatally which of them are going to do really well and which of them are going to have degrees of pulmonary hypoplasia or pulmonary hypertension that mean that they really are in a life-threatening circumstance. And so with that lens, what we built over the time we studied here is from creation through 2018, is that we found, out of the patients we met, about 39% of them had an underlying cardiac difference. About 23% had congenital anomalies. We also met lots of kids with neurologic differences, genetic differences, renal differences, pulmonary differences. And a lot of that is because there was not a certain prognosis for most of these kids. Because I was getting ready to give this talk, I actually went back and I looked at really high level at the data we have. And so we have now met more than 1,100 patients since the Fetal Health Center opened its doors and involved palliative care. And really, what was interesting to me is that the diagnostic breakdown is the exact same order, slightly different percentages. Another 650 patients later. And so I think that this really has proven to be a way for us to engage and continue to provide support in these circumstances. The main reason we were publishing this data is not to say, oh, hey, look at all these kids we meet. Here's some criteria for you to consider. What we were really wanting to do is talk a little bit about what this looks like. And then on the next slide, we'll talk a little bit about what the outcomes were as far as the babies were concerned. So when we've talked about this work before, some of the questions are like, how do you logistically make this happen? And so I wanted to go ahead and share that here in this space. Really, it's that a pregnant patient gets referred from that big map I shared with earlier. Um, the map is expanding, so we now really are seeing patients from nearly every state that we border. And that patient gets referred to the fetal health center because of some fetal concern that's been diagnosed. Usually that pregnant patient has seen their local OB, has made it probably to a first pass of a maternal fetal medicine physician, who then says, no, like this baby really needs the level of care that could happen with the children's hospital. And so they are referred on our way. Within the fetal health center, that patient is then assessed, usually with an appointment, with ultrasounds, with maybe their first visit with the cardiologist to confirm the fetal concerns and findings. And once those are confirmed, is when something we call the integrated consult gets scheduled. And that integrated consult is really when the neonatology team and our team and any of the relevant specialty teams, that could be the cardiologist, it could be the nephrologist. That's when we sit down with the pregnant patient and the support people for them, and talk through, here's what we understand is going on with baby. Here are the options for how we're going to manage and approach care at delivery and in the time after. And that time after could range right from the patient with hypoplastic left heart to conversations about the stages of repair and the future adulthood need to consider transplantation. So way future forecasting in these meetings. And then families get to come back and have what we call our PACT NEO, or the palliative care team and neonatology consult. And really, it's at that meeting that we sit down and talk really in whatever detail the family feels is helpful, about what delivery will look like, what the neonatology care plan will be, what those first hours and days will look like. And then our team has a chance to build deeper rapport and find out more about what else is happening in this pregnant patient's life, that's going to impact how she shows up, how the family shows up for the patient, that we're going to be taking care of. And so really that helps us set the stage for what care needs to look like when that patient is delivered. And while we're starting to think through what this baby will need when they're born, ongoing care is delivered by the maternal fetal medicine team. It sort of happens simultaneously. So they get that little arrow in line at the bottom of the slide to think about that a little bit more. And so back to why we published this, really what we were wanting to point out is that our involvement as the palliative care team in these integrated consults and these PAC Neo consults didn't mean that the baby was going to die. And so we wanted to see and to show what what were these outcomes. And so we looked at all of the babies who had been born alive, and realized that yes, we had had 172 deaths. And at the same time, we had another 218 who were alive and either still being actively followed by our team because the complexities of their healthcare continued, or had been discharged from our team because they had made enough improvement that the answer was no longer the same one for that surprise question that was asked at the beginning. We would suddenly be surprised if they died in the next 12 months. And so what this set the stage for is just helping to open up that palliative care could be about more than the imminently dying patient, which in at the time, more than a decade ago, was a little bit of a novel attitude to take within neonatology and palliative care. I can pause here and just see what other questions have come up before moving into the not perinatal space, or I can keep going with the slides as planned. Does anybody have a strong preference? And Natalie or Erin, I might look to you just to keep an eye on the chat.
I haven't seen anything come through in the chat, so if you want to keep going and then we can allow space at the end.
Perfect. I love it. Realize it was a good pause point just in case. So this idea of uncertainty, of the surprise question, really seemed to be worth holding on to, and really for me, came up again as the hospital was building a specific small baby unit. And so as you think about what is peri-viability, you can look at the ACOG definitions, looking at the data we have across the country. It still really is evident that prior to 25 weeks gestational age, roughly half of those babies will survive. A lot of those babies will go on to have morbidity, and even if not mortality. And then we also recognize that there are these other non-modifiable factors that impact survival, such as birth weight, sex, plurality, and the presence of congenital anomalies. And so, to sound like a broken record, quite intentionally, if you think about how the criteria questions apply, would you be surprised if this child died in the next 12 months? Does the patient have an uncertain prognosis? Do I anticipate complex medical decision making? We felt that really the answer was that based on these criteria questions, palliative care had a reason to be in the small baby unit. And so we decided to do a QI project like all dorky doctors. And what we settled on was to really think through our small baby unit project as being designed to focus on those babies who are born at less than 25 weeks gestation, and those babies who are born at less than 700 grams. And this truly just came from what we knew about the mortality data. We looked at the baseline of, okay, like in the first year that the SBU was open, really first 11 months, the unit had 68 admissions. 32 of those patients were less than 25 weeks or less than 700 grams. And we had only met 10 of those 32. And so 31%. We did meet an additional 8 or 26% to make a total of 26% of all the SBU babies. Usually those additional 8 were because of other congenital anomaly concerns that had come up. Over the course of our QI project, just serving as a reminder of joining a monthly SBU team meeting, we were able to move the needle on this a little bit. The number of admissions was remarkably similar for the 12 months of the project. And we were able to meet 22 or 68% of all of the patients who met criteria. And we then met an additional 11. And so in total, we had moved to meeting 46% of all of the small baby unit babies. What we found is that, really part of the impetus for this project was from the bedside nurses who saw what role we were playing in other patients we were involved in and said, these moms and dads and families need this support too. And really, part of the value add was for the patients, and part of the value add was for the staff in many ways. All of this corresponded too with what we were doing as far as other patients across our NICU census. And so really like thinking beyond the fetal health prenatal consults and the SBU sort of trigger of certain prematurity or gestational weight, we meet plenty of other patients too. We meet babies with severe BPD. And aside from straightforward BPD, are typically an automatic consult within the power plan that's generated for tracheostomy placement. We also meet a lot of babies with other postnatal life-threatening conditions. So babies that come in with profound acidosis and HIE or intractable seizures. We recently met a baby with a profound coagulopathy. We meet babies with liver failure. We meet babies with muscular disorders or other reasons for hypotonia that's going to impact their breathing and feeding and have complex medical decision making. And certainly those with metabolic or genetic conditions that maybe we didn't know prenatally, but become evident in those first days, weeks, or months that they're in our NICU. And so because of all of these sort of structural components for criteria, through helping other people start to recognize these questions, we follow about 40% to 50% of the entire NICU census on any given day. And so that's a lot of babies. And a lot of you may be wondering, well, what the heck do you do with all of that? What do you do when you show up for these families? And so I want to spend another, 15 minutes or so talking about that. So our team very much focuses on the idea that the role of palliative care in the NICU is to show up with families and sort of be with them and the medical team as they hope for the best and prepare for the rest. And really what that means in practical terms is doing a lot of rapport building and understanding what families are hoping for. And then understanding what the families and or the medical team are worried might be going to happen. And so those two things for us are really highlighted by the idea of parallel planning. Which when I tried to search that in PubMed does not come up as something. So I decided we should talk a little bit about what it actually means. So parallel planning is this idea that you simultaneously plan for two what might be very different outcomes. And so one of these parallels may be the miracle that a family is hoping for. One of these parallels may be the improve stability with the use of VEC so that hopefully we get some better lung recruitment and manage to wean the settings to a sustainable volume or the ECMO flows to a sustainable place. And maybe one of these parallels is that we're really worried we don't think that'll happen. And so we need to be anticipating and thinking about what do we do then? What does the family want to ensure they experience with their child before that end of life? And so these parallel planning conversations can really help us figure out where to go if we hit one of these parallel roads that is not what we were hoping we'd land on. And so a lot of the work here plays into one of the earlier questions somebody had posed as far as like, what do you do with the family who wants all of the available treatments considered? And so I think a lot of that work is a case by case situation. And so I can't give specifics. And I think a lot of it is trying to understand what that motivator is. And I think every palliative care doc has probably cared for a child where the main driver is that they just don't want their child to die. And so really sitting in that space of that grief can be a starting place for those conversations of what if. And sometimes that takes time. And so that's part of why having a specialty palliative care team that might have a different ability to just sit as families are processing than the neonatologist caring for 20 other kids, many who are critically ill, is able to have. And so it's not from a place of each of you couldn't also have the skill set. A piece of this is really that our job is to show up and just be there a little differently because I'm not the one going and putting in lines or responding to the rapid response or an unplanned extubation. And so figuring out a way to balance that together is what's really important for a functional relationship of palliative care in the NICU. Because some of what parallel planning includes is end of life planning, I put in just a little plug for this thing called a policy statement that the AAP put out. And it kind of makes me happy that I'm on there and Renee's on there and she's who's doing this again next time you have a webinar. Really, this was that we realized that the AAP didn't have any policy specific to what quality end of life care might look like or how to approach it or think about it. And so we went through the process of requesting a new policy and offering what we thought it should include and incorporate. And I learned a lot during this process, and I'm really proud of what we were able to put out there. And so parallel planning and more concepts about what is advanced care planning and what counseling might you actually provide as you're nearing end of life shows up in the policy statement here. I have lots more I could say about that, but I'm going to move to the final couple of things. Because the criteria I have outlined could mean such a volume of patients, it does then become important to have a pruning stage. And so if earlier on the slide, it was that little seedling as we thought about what patients can palliative care help, who can be the palliative care champions, what are the different care models that make sense for us? eventually you hit that place where you have to think about, I can't sit and have these conversations with 60 kids every day. And so, as much as I am there to fill in that time and space gap that the neonatologist may have, I need to figure out these other ways to know, where am I really adding value? How do I ensure that my colleagues have those primary palliative care skills, um, so that they don't lose their abilities to have these conversations without calling for a consult? And then introducing this idea of a pause, or even of graduating or discharging patients. So I talked about the discharging of patients a little bit earlier, and this may feel like a silly topic to a lot of trainees, right? Like, the infectious disease team signs off all the time. You graduate patients from needing cardiac follow-up not that unfrequently. But for palliative care, so much of what is built into the role we play is continuity, and being there in that longitudinal space. There was some resistance to this idea of graduating patients, discharging patients, or even the pause, which is our equivalent of signing off, even during an inpatient stay. And so, as our team got busier and busier because people were seeing the value as these criteria were being met, we were meeting patients upstream who maybe then had their CDH repaired, who didn't need to stay on pulmonary hypertension meds, who were figuring out how to eat by mouth, and really no longer needed to be where we, as the palliative care specialists, were spending our time. And so we developed and even managed to copyright what we call our pause criteria. And so what this really means to us is, this is not the same as graduating and saying, well, your palliative care needs are so behind you that we're going to say, go live life now. This is more for the patients who may still be in the hospital and yet may not need us checking in their charts and at their bedside in the same way they did early on. And so the criteria, because as I mentioned, we meet as part of the tracheostomy pathway. Once patients are on a full-time home ventilator, and are really mostly working on that training and the discharge planning and figuring out the home nursing, we say, okay, we're going to pause the frequency of our check-ins because you're going on that path. We're still not actually graduating you because we know that going home little with a trach can be risky. Similar for those who get a tracheostomy after a brain injury of any sort, TBI or hypoxic ischemic. We develop criteria for the extreme prematurity. So this goes back to our SBU criteria. And what we found, right, is some of these kids do so freaking fantastic. Once they're on low flow or less for a couple of weeks, we say, okay, BPD is not going to be your major issue. Once they figure out how to take a bottle by mouth or have their G tube in, we say, okay, like, we've covered the feeding challenges. Once we know that they're, uh, uh, um, their ventricular hemorrhages are like a grade 2 or 3 and not 4 with progression, we say, okay, like, you've done this preemie thing. You're still a preemie and in a NICU, so we're not going to actually graduate you yet. But we're gonna sign off. We're gonna pause for now. Similarly, with those who develop short bowel syndrome because of a SIP or some other event, if you are a baby born and needing CRRT and then peritoneal dialysis, once you're stable on that PD auto-cycler, we say, okay, like you're gonna make it out of this hospital, we think. Like we're gonna pause our check-ins. And so doing these pause criteria have allowed us to then have the bandwidth to go back to the bedside of those early on diagnoses, while the reality of being a parent in the NICU and the risk of coming around the corner and walking upon a code scene is really real, and that trauma is present. And so this is what has worked functionally for us, as we think about criteria for when to get involved. It felt really important to think about that criteria for when to say, okay, I think you guys got this now. And so as I put together all of these slides, I did, as you saw on the PubMed little slide at the beginning, I went back. I found a couple new articles that excited me because they're really talking about what can the next steps beyond the like program development papers start to look like. And so some colleagues are working on actual support interventions for women pregnant with a baby with a life-limiting fetal condition. Because of the consideration that we may have more and more children with differences in need of palliative care being born, they started talking about what evidence do we have for the role of palliative care and what palliative care can offer and what do we still need to study. And so I think both of these just really are exciting ways to think about what is that next phase for making the case for why does palliative care have a benefit within patients with a CDH? Why would you involve palliative care for the kid with single ventricle physiology? What benefit do they add? And I know that there are other slightly older papers out there looking at maternal health outcomes in particular, and showing some positive results. But we got a long way to go as far as building that part of the evidence around ways to better define the criteria and the role for what we do in the NICU. So I know there is one more slide that we'll sort of have up in the background maybe somewhere as we take any questions.
So, thank you so much. That was wonderful. There were a couple of questions that some people put in the question and answer place. One of them says, do you have a script that you offer your neonatology colleagues for introducing your team?
So I don't have a particular script. You know, this is one of the ways that having some criteria can really help, because it can be really straightforward. Just like if you're starting triple antibiotics on a baby, you get a consult for infectious disease. If you are born at less than 25 weeks, you get a consult for palliative care. And so having criteria can take some of the shock and awe away from what that might feel like. What we typically recommend for our team is that palliative care is a team who we invite to meet some of our most seriously ill babies, to help make sure we do right by your baby and offer you the support you need as you face this level of uncertainty and concern about how they're going to do. And so in the fetal health center, I'll usually say, you know, our team gets invited in whenever there are babies diagnosed with a lot of really complicated differences, when we don't know for sure what that's going to mean once they're out here in the world. And I leave it at that, because that's the truth, and is straightforward. Certainly, maybe 10% of the time, I meet a family who is familiar with the term palliative care. It is not every family. And sometimes will watch their face for a reaction as I introduce myself as being a doctor on the palliative care team. Um, and that then helps me know, hey, I noticed your face changed a little bit. What is your experience? And allows me to just sort of come from curious and learn a little bit more. And because we meet babies all the time who we graduate, we are able to be like, we can be there for children who are really who were really worried are not going to survive. And our bigger role is to be there to support you through the roller coaster that is the NICU and whatever else may come. Um, and I'm like, that may be really hard to understand right now as you're meeting me, right? Like I won't imagine that they can build trust instantly. But really say, we'll keep showing up and trying to support you and help you understand things. So that's a lot of different ways to approach it. Circling back for like the one-liner, I usually just say that we're a team that gets invited in whenever the medical story gets especially complicated, to help offer that support continuity.
Wonderful. And then there was another question here. They said it's great to see the data that you presented from your team efforts. But for your SBU QI project, did you have any other positive or negative metrics that you tracked as your team's involvement grew?
Absolutely. We tracked many other pieces of this. Our one of our biggest issues was timely consult. We often found that if we got it notified of the consult when the baby was admitted and the moms were still 4 hours away, inpatient after a stat C-section, our timeliness of consultations diminished significantly just because of the SBU. And so we really, had to come up with some um, countermeasures to adjust for what that looks like. We are a team who says we are here, and we, unlike some of the other consulting services, are not going to force you to say hi to us every day. And I think that for our team helped offset those families who were just too overwhelmed or distressed to engage, feel permission to say, hey, yeah, I don't need a visit today if we connected at the bedside. Um, so I think that out of all of the spaces where we are, I still feel like we've got room to improve how we show up in the SBU. I think from a sort of tangible numbers, quality improvement, there's still these gaps of what do you do with the baby who's transferred here when they're 2 months old, but they were born at 24 weeks and 500 grams. Is that still an automatic consult? Where do we fit there? And so there are still plenty of gaps and areas for us to work on a little bit further. So I never intend to say we're perfect, or that there aren't areas to keep working on. If you've got thoughts, I'm happy to hear them too.
Okay, another question just came in. It says, how do you partner with your neonatology team in situations where a case transitions to comfort care?
Um, it sort of depends on what our role has been before that transition. And so I say that because we were just talking about the small baby unit and how it can take us a while to meet a mom. And so sometimes a baby comes in like so sick that they die within a day or two of their admission and arrival. And certainly I don't have any greater rapport or expertise necessarily in what to do as that child is dying. And often, having to meet additional people in that time is not helpful. And so there are some babies who have comfort care that I don't meet, and that is okay. Um, I think in other situations, the comfort care is sort of negotiated. I think that different colleagues have different level of comfort with the conversations and the plans. Um, you also don't know how your day is going to go. And so it may be that this is a day that the family planned to do a ventilator withdrawal, and you're getting pulled into some other emergency. And so, really, a lot of it, if we have transitioned to comfort care and we have time, we make a plan. What are the meds we're going to need? What are the symptoms we might see? Who is important to be with the family? We actually have a power plan for end of life scenarios outside of our ICUs that help us, in the ICUs too, because it's there as a standard to say, okay, we're going to have a huddle and we're going to make sure we've thought through the heartbeat recording and the siblings and the spiritual services piece and the questions about aftercare and autopsy and all of the things. And so having a end of life huddle is something that is routine across all of our units to help us know who's doing what so that we can best support the patient and the families in the midst of all of that. So not a clear cut one size fits all answer to the question about partnering around comfort care. But lots of ideas for ways that it sometimes goes and that it might make sense to make sure you have in place at your own institutions.
Right. Any other questions that Dr. Linebarger can answer? If not, thank you so much for that wonderful talk and kind of talking us through everything of the thought process that goes into the prenatal consults and the NICU consults. It was very, very helpful and can definitely be difficult to sit down and have all of those conversations as someone who's in that busy unit. So it's wonderful to have that additional support.
Well, thank you guys for the invitation and hope everybody has a good rest of their day.
You as well. Bye, Jenny.
Bye.